can. Okay. There you go. I'll just make sure we are on. Cool. Okay. So today we are going to. So this set of lectures is primarily about neuroimaging in multiple sclerosis, largely focused on the clinical application on the day-to-day practice of multiple sclerosis for general neurologists and also MS specialists. However, from an introduction point of view, there has a lot been going on in the understanding the pathology of multiple sclerosis and the pathophysiology of multiple sclerosis. And the MRI techniques has been really helpful in making this understanding there. At least the current knowledge we have has been obtained from pathological studies, but as well as from neuroimaging studies. So I thought that is the best to start with a briefing of what we do understand about the MS pathophysiology in the brain, with a focus on the pathological changes that happens in the brain in particular, before we proceed for the subsequent detailed imaging teachings about the different lesions and different pulse sequences that can be used. Yeah, mainly in the clinical practice, but somehow also in the advanced MRI techniques and the imaging research that you might come along as you try and read and develop your skills in MS practice and the MS knowledge, broadly speaking. So today we will discuss the how MS or how the MS pathology starts and evolves in the MS brain, and how this can be reflected on brain scans. So, because I assume we like you are like in my case when I started to develop a bit of understanding about multiple sclerosis, so I did not had the broad, solid understanding of the neuroimmunology. So I thought like to start with a brief. Like just a brief outline to what we need essentially from the basic neuroimmunology, and then we next jump into MS pathophysiology. So we have two main divisions in our immune repertoire on our immune system. The first is the let me try and get a slide. The first is the common one that is famously known to be involved in MS, which is the adaptive immune response, based or driven primarily by the lymphocytes. So the story for a lymphocyte to start to develop some autoimmune activity or any physiological, even a physiological activity against the bug or virus or whatever, is it all starts with a lymphocyte, which is either a B or T lymphocyte. So each cell on its own responds to one unique antigen, as you know. So we have a lot of cells. Each one responds to one random antigen, and when this particular antigen is exposed, for our case, it is something related to a tissue in the brain or in the spinal cord, and related to the pathology of MS. So these cells are alarmed or triggered. This particular cell, rather than any other lymphocyte, so it's very specific. And usually this is primed or started by one of the cells that presents this antigen to the naive, untrained lymphocytes, the initial lymphocytes. We call it naive lymphocytes. They are just an initial one, not activated when it is triggered by the antigen presenting cell, by its very unique antigen. So this is an alarm that this particular antigen is present in the body and it is foreign, and we need to react to it. So these alarmed or triggered naive lymphocytes travel to the lymph nodes primarily, some other tissues as well, but it is the lymph nodes primarily. So in the lymph nodes, they are well trained So they have developed more specificity towards the antigen, and they do replicate. They divide a lot, and have reshaping to their performance, and they have be more and more specific to the antigen in a process happens primarily in the secondary lymphatic organ, which is a lymph node. The primary one is a bone marrow, and the secondary, let's call that the lymph nodes for simplicity. So a naive lymphocyte, once triggered, travel back to a lymph node to be well trained and to be well refined, and then comes out of the lymphocyte as an activated lymphocyte. The activated lymphocytes is very well prepared to initiate an immune response, whether it is a B cell mediated, this antibody mediated into a plasma cell, or a B memory cell, or a T cell mediating the different mechanisms and the cytotoxic T cell. And these are actually the cells that travel to the brain to initiate or at least to participate in the immune response. However, this is not the full story, or actually there is an equivalently important part of the immune system called the innate immune system. Innate is not trained by any way. So innate responds to a wide variety of antigens, and it is just alarmed when there is something happening, where when the immune system is not sure what's going on, but there is definitely a risk or an alarm signal. So the innate immune response starts to react to it, and actually they do much of the antigen presentation to the more specialized adaptive immune system. So, and they are of two types for any given disease condition. So they are of two types. One of them is blood driven. So these some of the cells that circulate in the blood and travel specifically towards an inflamed site, that's the monocytes and the polymorphs. And there are some tissue resident innate cells, which are a slight modification to the monocyte during fetal development. Some of them hide in the tissues and acquire a name for each organ. In our case, because we are concerned with the brain, it's called a microglia. Microglia is embryologically belongs to a monocyte, but it has migrated, lived their whole life since our fetal life into the brain and stay there indefinitely. And they exert pretty much the same response or closer response to the monocytes. And when these cells are activated, so particularly the monocytes becomes a macrophage, and the microglia becomes the activated microglia, they contribute much to the initiation of the immune reaction or the inflammation, and also the maintenance of the reaction. So in the acute phase, they are the rapid responders because the lymphocytes takes a bit of time to travel back to the lymph node, to be well developed within the lymph nodes, and then emerge back again to initiate a response. So this takes time. However, the innate immune response is a very, very briskly responding. So it responds immediately towards any given pathogen within the brain, as we are speaking. But also, we start to understand that they are essential in maintaining a continuous level of damage and a continuous level of inflammation, and developing a chronicity of inflammation at some point. So briefly, this is what we do need at this point from the neuroimmunology. We don't need much more than that for our own sake. What happens in multiple sclerosis is that for something, we know that it is related to Epstein-Barr virus. Epstein-Barr virus lives within the lymphocytes, and for some reason, it perturbs the immune system in a way we poorly understand. And from that point, some cells start to be triggered against some antigen. We presume that this is the case, but however, it's still not 100% shown. So they are these cells that are triggered, and likely these are, let me try my markings. Okay, so we will start our story with these naive immune cells who have been alarmed, activated by a hack through the Epstein-Barr virus. Let's assume that this is the case. So the immune cells, these very immune cells, these very lymphocytes, travel to again to the lymph nodes to initiate the uh, um, follicular reaction. The follicles, these tiny bits here within the lymph nodes, are called the follicle, where the B and T lymphocytes mature together and develop more specificity towards the antigens. So this follicular response and follicular reaction happen within the lymph nodes, and then they travel back to the bloodstream to reach their target. For our own case, it is in the brain tissue, and you can imagine that the innate immune response has already been alarmed and activated a leak in the blood-brain barrier for them to travel and reach the target site within the brain and the spinal cord. So, and this actually happens every single time there is a relapse. So for every relapse, this particular lymphocyte maturation. So it's a naive maturation, activated lymphocytes, and then traveling to their specific site through a leak in the blood-brain barrier, initiate an inflammatory reaction, being an MS lesion, silent, or a relapse through a relapse to in the patient. So it's every single time. This is what is a relapse should ideally, from a pathological point of view, should happen. This is what should happen in there. Over time, when the when a number of cells starts to trafficking, if we call this a trafficking problem. So let me remove everything. Here are more drawings. Okay, so we with ongoing trafficking of these lymphocytes, they start to have their own residence within the CNS compartment, within the meninges, and they start to develop what looks like the lymph node here. This is, if we call this a secondary follicle, this is called a tertiary follicle because it looks like a lymphoid follicle, which is important for support, maturation, and survival of the lymphocyte, B and T lymphocytes. They are essentially doing the same job, but here in this case, it is within the meninges of the brain. This process happens in any chronic infection. Like, for example, when let's assume a case of Sjogren syndrome. So the same tertiary lymphoid follicles, you will find the same tertiary lymphoid follicles around the salivary glands, and some macrophages and some local resident monocytes will continue to flourish and continue and sustain the inflammation. The same happened with the brain. Same happened with any, as much as you can imagine, any like, for example, any chronic abscess. Let's say the case, you will find some secondary lymphoid reaction in the lymph nodes initially, and then subsequently, when it becomes chronic, you will find some evidence of a tertiary lymphoid structure or tertiary follicles is it local within the site of continuous inflammation to support the survival of the immune cells. And actually, the tissue resident phagocyte, which is the microglia, starts to become activated. An activated microglia transformed from this very ramified form to a form similar to amoeba, large with multiple pods, and exerting significant phagocytosis, and also exerting an important secretory function to different chemokines and different reactive oxygen species, and which, if you can imagine, these cells continuously, if they continue indefinitely to exert these stress chemokines, over time they will start to develop some axonal damage throughout the whole brain, because it is not the process of microglia activation spreads throughout the brain, not just the focal lesions. And the oxidative stress, which means essentially it means like the an early loss or a rapid loss to the mitochondria, and the oxygen products are really toxic to the tissues. So you start to have some early loss of the axons, early loss of the neurons, and what's called a virtual hypoxia, because the cells are devoid of mitochondria without this sophistication anyway. So activated microglia is maintaining a toxic response to the nervous tissue, and the tertiary follicle is helpful in maintaining a survival support to the lymphocytes. So you don't, over time, for multiple sclerosis, you don't need a continuous trafficking over the blood-brain barrier. And this is actually what happens to people transforming from relapsing remitting to a secondary progressive stage. It is essentially the number of lesions starts to get lower, number of relapses start to get lower, but the progression starts to happen, and the blood-brain barrier is intact at this stage. But it is intact. However, within the CNS compartment, there is a full set of immune reaction that is able to sustain a continuous inflammation happening. And this is really toxic to the nervous tissue environment. And what you might expect is an accelerated rate of axonal loss, cellular loss, with a progression of the disease. And this is what actually happens in any progressive phase of the disease, being a primary progressive or secondary progressive. Okay, so moving on, I will start to get some focus into what are the pathological changes happening now. Broadly speaking, we will classify the damage happening into a white matter damage and a cortical damage. And also each type, white matter and cortical, will be further subdivided into a focal damage and a diffuse damage. So going through that, we will start with the white matter. So what we would expect from the white matter damage, I will start with the diffuse pathology, because we over time, particularly when the MRI criterion started to develop in the early 20s, we tended to consider MS as just a disease of the focal lesions, which is essentially not true. So MS is a biological disease with focal phenomena as part of it. And actually what happens is that the whole brain literally is involved in a way or another. And the normal appearing white matter is a good example to it. So the normal appearing white matter is from a pathological point of view, is far from being normal. It's not normal. So the axonal density is different in the normal tissue, in the normal appearing tissue, compared to a normal individual. So the less axons, more microglia transformed from the ramified form to the amoeboid form, and there are plenty of them active. And you would expect these activated microglia continuously secreting their chemokines and calling out lymphocytes to jump in and initiate some form of inflammation. And from a conventional MRI point of view, it appears to be normal. It appears to be a normal tissue. Once we start to develop some quantitative MRI techniques and non-conventional techniques, we started to pick up some microscopic damage. Microscopic damage, it is something that is in the very small voxel scale, and you are unable to identify it in a single patient, but usually you group a group of MS patients and you compare them to the normal individual, and you compare the values in different sites, so that you can clearly see that there is some sort of abnormality. And actually, many techniques has been developed, but the most famous is the MTR, the magnetization transfer sequences, which are reflective of the myelin integrity. So they are not particularly picking up any microglial activations. They are not particularly imaging the axons themselves, which is the real pathology. They are a surrogate to what's happening in the pathology. So they are detecting the myelin integrity, and they are able to develop some microstructural damage in what looks like a normal scan. Another technique, which is a diffusion based on the diffusion weighted MRI sequence, is called the DTI, diffusion tensor imaging, which is largely reflective of the axonal integrity, because it picks up how the water trafficking within an axon performs, and you will be able to detect problems with this trafficking of the water content in a normal appearing white matter. So far, you would conclude that this is just a normal appearing white matter. However, this is not all the fun. The funny part, or the fun part of this story, is that we are able, through the DTI and MTR sequences, we are able to predict where exactly the subsequent lesion should happen or will happen, because we were able to pick in some changes that are in certain spots of the white matter, that makes the likelihood of a lesion and the next activity is coming in this particular region. And it is actually a very insightful piece of information to the pathologist, because it looks like that the continuous microglial activations, they use the background activities, the background inflammatory activity that's happening in the brain, starts to build up into certain spots, calling for the lymphocytes. The lymphocytes go to the lymph node, train themselves, come back as a focal lesion with an MS relapse at the end of the day. So if it is a chicken and an egg story, the normal appearing white matter comes first, and then comes the focal damage. Also worth mentioning that some we in our conventional scans, we sometimes we feel like a white matter. There's no focal lesion, but they look dirty. They have a subtle, diffuse hyper intensity. This is different from the normal appearing white matter. Normal appearing white matter is typically normal, at least in the MRI, conventional MRI scan. The dirty appearance is a reflection of gliosis and a reflection of a significant loss of myelin, which sometimes happen in a non-focal manner, particularly with people with ongoing disease and progressive forms of the disease. And I've pictured a couple of scans to show you what can be, how can it be imagined from a microstructural level. So the integrity of the axons and the myelin is highly abnormal in the lesion, and with a gradient surrounding the lesion as well. And finally, you will end up with a background of an altered signal, or altered normal appearing white matter in the rest of the brain. But they tend to be more more of an affection in the area surrounding the lesion. This is the actual lesion, if we can say, it's the actual lesion itself. But there is a surrounding pattern of activated microglia. All the surrounding are activated microglia, and in the core there are the lymphocytes. This is, I've picked it up from one of the studies that was able confidently to predict the site of a normal appearing white matter where a lesion has developed in the follow-up scans. So it is quite intuitive to think of normal appearing white matter as a predecessor, by some way or another, as a predecessor by order of few months, by the way, to a subsequent active lesion. And here comes what we really are interested of. It's the focal lesions within the brain and the spinal cord. So they are, as we have agreed, this emerges from a normal appearing white matter, and in the literature, maybe some of us know that they are of 4 different patterns. There are 4 different pathological reactions in the focal lesion, in any focal MS lesion. Each patient has one of the fours, but only one for each patient. So they are not interchangeable. They are more likely reflective of the type of the immune reaction that a patient can exert in multiple sclerosis. So the four types are not interchangeable or does not alternate within a patient, but they can be different from one patient to another. And from a pathological point of view, virtually there is no single focal lesion that does not occur outside the central vein. There must be a vein around every single lesion. What matters for us is that some veins are visible. We are able to see the central vein in a conventional scan, and some veins are not, and they are very, very tiny and microscopic. But virtually all the lesions are around the vein. And they can be active and chronic. I think this is something we're all aware of. And what is really important is that they are diagnostic. We are able to see these focal lesions in the MRI scans, and we are able to see the central vein with high field scanner and susceptibility weighted scan. And actually, I brought this image on the left in particular to give you the gist of having the lesions surrounding a vein, because it is really interesting to know that the Virchow-Robin spaces are broadly vascular spaces, and they contain arteries and veins. So the Virchow-Robin space is surrounding an artery and surrounding a vein. And guess what? These very veins happen to be a site of inflammation to MS lesions. So we can imagine this is a very, very important clinical clue we will discuss in much, much detail in a subsequent teaching about the white matter lesions, focal white matter lesions, but just to at least to give a note on that. So if you can see, all the lesions follow all the MS lesions follow one of these radial patterns in the white matter tract. It is oriented within a specific design, and it's not haphazardly. So for example, this lesion happening within this curve, and this one is likely occurring within that field, and this one is radiating this side. This one is happening within a radiation of that pattern and that pattern. So and this is really a very, very, very helpful diagnostic clue. We're not speaking about that today, but just to give a hint of that. So virtually all the focal lesions will follow one of the radial patterns that we can guess them from the Virchow-Robin spaces. So on the left, definitely on the left is just a person with a markedly dilated Virchow-Robin spaces but does not have MS, and on the right is a patient with MS. Moving on, here's how I can imagine how an MS lesion appears. So these are initially in the relapsing remitting phase. Lesions are acute. Most of the lesions are acute. From a pathological definition or a pathological point of view, an acute lesion is formed primarily by lymphocytes, and I have drawn them into by the red dots. Every red dot is a lymphocyte, so they are quite condensed within the lesion. And within the lesion as well, you will find some yellow dots. These yellow dots are activated microglia, and some very faint green. I'm not sure if you are able to see them. They are just macrophages. Most of the lesions in the relapsing remitting phase of the disease follow this pathological pattern. As the patient progressed from relapsing remitting to secondary progressive, these lesions start to develop some sort of chronicity over time, and they change to the next pattern. So the next pattern is not particularly florid with lymphocytes. So there are no abundance in the lymphocytes. And as you can see, the yellow ones are activated microglia as they start to develop very dense aggregation around the lesion, particularly on the periphery of the lesion. And this is really, we come to know a very nice imaging trick that allow us to predict that this is a chronic lesion, because these activated microglia release oxygen species, reactive oxygen species that we have discussed, and these reactive oxygen species are able to oxidize iron either within the blood or within the cells. And because we have a sequence with iron susceptibility, so you would expect in the chronic lesion to start to develop some hypo-intensity in the SWI sequence or the gradient echo sequence, and remarking of the microglia. This is a process, the hypo-intensity, the iron deposition, is a process driven by the microglia and the macrophages, but by abundance, it is a microglia. So the microglia deposits a lot of iron, and this iron can be picked up into the SWI. And I think it is very soon to be announced as one of the diagnostic signs to multiple sclerosis, in the sign called paramagnetic REM. Paramagnetic means hypointensity in SWI, and REM because they are usually, so this is the same lesion but in a closer look, so you start to develop some hypointensity in all the lesions that transforms into a chronic form, and it can be really in a typical nice ring form like this lesion as well. I've seen some just comments. Let me without it might happen for a relapse without a gad enhancing lesion. It can happen, but it can happen from a technical point of view, but because there are possibilities that you don't get any enhancement because of the technique and because of the timing of the scan, but from a pathological point of view, there should be a leak to allow the lymphocytes to jump in. So Dr. Yasser is asking about the lines, the Burkow-Robin lines or central vein lines, if they are not matching exactly these lines. If most of the lesions are not matching this line, it is likely not to be that this is not likely MS. If most lesions follows this pattern, follows the linear pattern, so then you make a conclusion that this is MS. And actually, it can be helpful in challenging cases with multiple white matter hyperintensities. And here's another example to the central vein sign. On the right side, on the right hand side, you will see a gradient echo. This is a gradient echo sequence, and this is a vein. This is a vein. This is a vein as well. Sometimes these veins are traveling sideways, like in this direction, but some veins are traveling upside or down upwards. So you would be able to pick it as a dot, which is this lesion. This lesion here is an example. This one is another example, because some veins travel radially across the cerebral hemisphere, so not necessarily on the axis, on the long axis or the plane of your axial scan. So maybe this one is a central vein as well. But virtually speaking, or pathologically speaking, every single vein, every single lesion has a vein around it for MS. And the cortical pathology is way interesting as well, and developed an attention over time. So again, we would classify that as diffuse, which is let's say the volume loss and the subpial demyelination, and some focal lesions can happen as well. I find it a bit confusing to call them by numbers, lesion category. There are 4 different types of cortical lesions, or the cortical pathologies that can affect the cortex. I think the numbers are confusing, so I will ignore these numbers, and we will just go through them. What can happen, or what can happen in different lesions in the cortex of the brain. So on your right hand side is a normal high field scanning to the cerebral cortex, and that's a zoom in to imagine what's happening here. So again, as we have agreed, all the lesions comes within around the central vein. So this is one type of the 4 types of cortical lesions. So can you imagine? Can you see these tiny hypointensities in these lines, these very lines, and the bigger subpile or subpile blood vessel here? So I've labeled them in blue so you are able to appreciate them. So one type of lesion is called the intracortical. It happens as any other white matter lesion around the central vein and stays within the cortex. This is called the intracortical one. This is not the most common. This is the least common type. What happens essentially on the white matter happens again in the gray matter or in the cortex, but this is a rare occurrence, given that the cortex is a tiny strip and it's very difficult to pick it up in any given scan. What is more prevalent is the subpile demyelination pattern. So if you can see, this is a sulcus. If we assume that this is a sulcus, and a typical appearance of a subpile lesion is that a lesion that starts to demyelinate the cerebral cortex, but not to the full thickness of it. So it's just spreading over distances, particularly over the sulci, and not reaching the full thickness of the cortex, and definitely not reaching the white matter. This is the most common one, and again, this is least visible, one of the least visible lesions. It's difficult to see this pattern of demyelination on the MRI. But this one particularly grabbed an interesting attention because this does not happen by any of the immune reactions we have been speaking about. It is just a demyelination, no lymphocytes there, few microglia around, and that's the whole story. And it is presumed that from that lesion, we were likely to conclude that some of the demyelination, at least what happens in the cortex, happens because of a soluble factor. And this soluble factor comes from a lymphoid follicle, a tertiary lymphoid follicle that is likely in the meninges overlying the cerebral cortex. So one of the follicles, or the components of the follicles and the cells, secrete some cytokines that are able to exert a demyelination to the cortex, and you will end up with a subpile demyelination. So we started with this type, the intracortical one, to the subpile one. Sometimes this subpile is much extensive and involves the whole thickness, which is type 3 one, this one here. So it is essentially the same subpile lesion number 2, but it is just involved the whole thickness of the cortex. No drama, it's just the same lesion. And the easiest to pick is a type that is again around a central vein, but extends to the white matter as well, which is more frequent and more easy to pick. And this is actually not particularly a completely intrinsic cortical lesion. It is more of a cortical juxtacortical lesion. So this is the whole story. This is the whole thing you need to know about the types of cortical lesions in people with MS. In imaging-wise, it is difficult to see the most common, the subpile, whether the incomplete or the complete. Less difficult to see the intracortical one, and much easy to see this one, the cortical juxtacortical one. It is the most diagnostic, is the least to pick up, which is quite unfortunate for us. So the most to confirm a diagnosis would be the subpile ones, but these subpile ones are practically for the pathologist. They are able to see it under the microscope, but they are very difficult to see under the scan. Sometimes we are able to see that one, which tends to be specific to MS, and most common we see that one, which is not specific by any means, or the least specific from the 4 types. let's move on. And here are the different four types, or at least the different three types that we can see. This is the most common one. This is a lesion that starts in the cortex, but spreads down to the white matter area. And this is actually a double vision recovery. As you might have guessed, the double vision recovery is a modification to the flare sequence, just to have a better of appreciation to the abnormal signal in the cortical ribbon. And this tiny bit is equivalent to the intracortical one here. As you can see, it's a little bit difficult to pick. It's very it's not the easiest one to pick. Again, this is another intracortical one. These tiny bits, these ones, that one, which looks like a rod within a cortex. So, like if you can draw like this way, draw it this way. So these ones are more and more specific to the all the lesions we have picked up here, and it is as presumed to be related to the subpile demyelination, but it is not a confirmation actually. So it can be the other types, but usually the ones that are not dot, they are likely more to spread few millimeters around through the cortical ribbon, are more specific in the double vision recovery as MS lesions. Briefly, we're almost finishing now. This was just briefly to see how the different pathologies we have spoken about, how the different pathologies form different clinical phenotypes. So in people with relapsing remitting, as we have agreed, most of the lesions are active as you can see by the green ones, by the green patterns, green focal lesions, and over time, some of these lesions becomes remyelinated and more develop into either a healed lesion with shadow myelination. So some myelination happens, and some of them not, and continue to be active like this way. But also over time, some people people with relapsing remitting start to develop some cortical changes in the subpile demyelination pattern. At the time that people who develop secondary progressive multiple sclerosis, there are two important phenomena happens. The previous remyelination that was successful initially starts to fail. So it's a failed remyelination, broadly speaking, for these lesions and also for these lesions in the green. And the cortical pathology starts to be more extensive. What is really interesting in the cortical pathology is that it tends to happen in the basal parts of the brain rather than in the top parts of the brain, because if you think about it, this is a soluble factor driving this pathology, and it tends to be affected with the gravity, and they float to this base of the brain, and also the bases of the sulci and gyri. So on the sulci, so they are more likely to be on the sulci here than onto the outer surface of the brain. So it's most of them around the insula, deep sulci within the brain. And actually, these are drawings to actual pathological specimens from one of the articles. So it tends to be more extensive in the lower part, more extensive in the sylvians, around the insular regions, but it's somehow difficult for us to see on a conventional scan. Also, people with primary progressive phenotypes, they have very little active lesions. Most of the lesions that has happened already had a sort of remyelination, sorry. But however, the main obvious phenomenon that happens from the early years of diagnosis to people with primary progressive MS is the early extensive involvement on the cortical demyelination. So less of the lymphocytes, more of a microglia, and more of the soluble factors that drive the cortical demyelination. I think this is all what I have for today. It is a bit of I know that these the different terminologies and different pathologies who are not familiar with our in our everyday practice, so it can be a bit challenging for some of us. However, it's just I prefer to have a dedicated one just to outline everything we need to keep for our subsequent lectures. In the next lecture, we're going to give a bit of a focus to the cortical ribbons and the cortical pathologies that happens to people with MS. Maybe it would be good if we give a bit of a comparison to what happens in MS lesions in the cortical ribbon, in the cortical space, compared to other diagnoses